All right, hello everybody. So today Claudia and I are going to be doing a case study just on the application for biofeedback training, both for fine motor control and balance. Oops.
I can pass.
This is a disclaimer. Okay, so we're talking about Mr. D. He's a 60-year-old male who has hypertension, dyslipidemia, sleep apnea, ex-smoker, and he has had right carotid stenosis distal to the origin of the right internal carotid artery. His presenting to acute care, he had left hemiparesis, mild slurred speech, and this was in December of 2012. He ended up having a right MCA CVA with watershed distribution. He underwent a microcarotid endarterectomy with patch in December, and then he was referred to the stroke early supported discharge team when he was discharged from acute care. We started seeing him kind of end of December, beginning of January for 7 weeks of in-home therapy. All right, so the client was assessed with the Canadian Occupational Performance Measure, and with the goals were bilateral upper extremity strengthening, being able to hold soap in his left hand. So his performance scores for the goals were 5, 4, and 5, and satisfaction scores were 2, 2, and 3. And hopefully nobody has any questions about the Canadian Occupational Performance Measure, but we'll move on. So just the second two goals were the ones we focused on as far as the biofeedback. He had impaired function in the left wrist, hand, and fingers, and his goal was to be able to hold a bar of soap in his left hand. A lot of our team members found that quite humorous to set as a goal, but it was very functional. With this, his grip strength was 30 pounds on the left and 60 pounds on the right. Box and blocks left were 15 blocks per minute, and then I ran it a second time just to see, and he fatigued a bit and only got 11 blocks. On his right side, it was 47 blocks per minute. He had limited active thumb opposition and adduction, unable to oppose to the fourth digit or beyond. Opposition to the second digit improved with repetition. So initially it wasn't full, but then it improved it when he did the movement more. Finger flexion was limited with the fourth and fifth digit off full flexion by 0.5 centimeters. And this improved with repetition as well. Client participated in bilateral fine motor program, including therapy, fine motor exercises, and activities. Second goal was to feel safe or comfortable walking as fast as he had before. So he wasn't concerned about being able to walk, but rather he could not walk as he could before. His timed up and go was 8 seconds with no aid. The Berg was 51 out of 56. He had issues on tandem stepping and reaching. Dynamic gait index score was 22. Difficulty with tandem stand and single leg stand as well as crossover. Bilateral lower extremity strength was functional and equal except for the right plantar and dorsiflexion, which both had a grade 4 on manual muscle testing. The client ambulated indoor independently without any aids. So we saw him daily, Monday to Friday, for 1 to 2 hour sessions, and he also worked on therapy in his own doing homework. In the fine motor exercises, he did facilitated active range of motion, plain active range of motion therapy, and a variety of fine motor activities. For lower extremity, he did strength and gait training, including sit to stand, heel raises, mini lunges, obstacle courses, forward walking with side-to-side head turns, tandem stand, single leg stand, tandem walk, and backwards walking. It was really interesting because with that goal, he actually didn't think he had any issues. He says he'd always been a little bit clumsy, but when we did the assessment, there was some higher level balance that we thought could use some improvement, and he agreed to work on it. So he did participate in neurogym therapy during home visits with the therapy assistant, and now Claudia is going to talk about that.
Okay, so here we're going to show the kind of sensors we used connected to the biofeedback machine. The big one, the white one, it's a pedal. So that's the one we use for balance exercises. And we have two different ones for upper extremity hand exercises. The one in the middle there, it looks like a stick. And we're going to show in a later picture how we adapt that to the wrist or to a digit for finger flexion and extension and other things that we can be creative with. And the first one there, it's like a button where the client will press and maintain that pressure. Okay, so for the left hand therapy, we chose the Pong game. Most clients, they enjoy that Pong game, which consists of a ball kicking and a bar underneath this ball, and they need to do the movement in order to go towards the ball. The bar moves towards where the ball is going to kick. So we did that with that stick electrode you saw in the previous slide, and we did that for finger flexion and extension and adduction and abduction. We also have a few other games in the biofeedback machine where we try a variety of games. We have a bar game that this client enjoyed, and that one, he needs to get that bar moving to stop underneath a block that changes the color in his scores if that bar changes to green. So it's a color kind of game.
And we actually had some video that we were going to try to present, but it's not working for us, sorry.
Yeah. Okay, and next is the balance therapy, which we use that white electrode, and that's like a pedal, kind of a electrode sensor, where client stands on top of those plates. And we also try different kind of games, but the idea is to work on side to side sway, shifting side to side, and sway anteriorly, posteriorly, like kind of limits of stability, balance exercise. And then we separate the both electrodes, left and right, one far from the other, and then client needs to kind of rush and step with the right or step with the left. And this is like a step reaction kind of balance exercise. And also we use other games, skier games and a car race game the machine has.
In the end, the outcomes were that his grip strength went from 30 pounds on the left to 60 pounds, and on the right it went from 25 to 85. And then, from 60 to 85, but increased to 25. He was able to complete a pinch strength assessment, which was not possible at all on the initial assessment. So his left lateral pinch was 17 pounds. His right lateral pinch was 25 pounds. And for box and blocks, his left went to 37 blocks and the right went to 61 blocks. So there was increase in all of the outcome measures. The other thing that he had was the strength was functional in his left wrist and for ulnar and radial deviation. However, he still needed work on control as it wasn't as accurate. The really big thing was that he reached his goal of being able to hold his soap in his left hand with showering, and he actually changed or updated his goals to be card shuffling for bilateral and flossing his back teeth with his left hand involvement. So functionally, he was finding that there was great improvement. For the balance, he scored 56 on the Berg, so that improved, and he scored 24 on the dynamic gait index. We found that he could have still benefited from ongoing therapy for the higher level balance, but he significantly improved functionally for that as well. If you look at the COPM scoring post-rehab, his bilateral upper extremity strength, the performance was 8, satisfaction score was 8. Holding the soap in the left hand went to 8 for performance and satisfaction. And feeling comfortable with walking was 7 and 7. So for performance score, there was a change of 3 for improvement, and satisfaction score 5.34. So those are statistically significant for the COPM. We ended up discharging Mr. D to a community rehab program where he is at this time continuing his therapy.
All right, so we get started. We might do it a little bit differently than what you guys have in the PowerPoint slides that you received before, just because of time. Anybody knows how much time we have left?
Have 35 minutes.
Oh, that's not too bad. Okay, so my name is Ghislain Blanchard. We're in Ottawa. I'm a physiotherapist, and I'm excited to talk to you today about Neurogym methodology, filling the gap between motor control theories and clinical work. So maybe, like me, as a young clinician, you remember your professor enthusiastically talking to you about evidence-based practice and searching the literature when putting together a treatment plan. As you might also have found out, the reality of clinical work is very much different between heavy caseload and sometimes administrative tasks. One simply starts to do what can be done. It brings me to the question, were motor control theory and evidence-based practice only good for school, or was it good for clinicians as well? And as many PT, one would start to do his best to see as many patients as possible, and the treatment plan would quickly be reduced to what can be done without too much risk. Now, I was happy to meet Dr. Native at one point, and I find out that following his PhD in kinesiology and a degree in physiotherapy, he developed a methodology which now makes it possible to apply motor control theories to everyday reality of the clinical work. This is true because the so-called Neurogym methodology was actually developed in a clinical setting, and that makes all the difference. So Dr. Native developed this with his different clients who suffer from stroke, TBI, spinal cord injury, etc. As he was trying to apply his knowledge about motor control, motor learning, and neuroplasticity to his treatment with patients, he also realized that some tools were needed to make it happen, so he just developed them. So the Neurogym methodology is actually a combination of many things. Some of it include balance and stability training, control and coordination training, mobility training is a big part of it, and strength training. However, as you might have found out in your career, it's not always easy to do all those things in a clinical setting. So Dr. Native developed some tools to enable the movement. And this is very important because in order to let neuroplasticity take place, and therefore relearning, we need to allow the client to actively experiment the movement and being able to initiate the movement. So the tools that Dr. Native developed were actually made to create such an environment where the client can initiate the movement. And I've seen that some people, some clinicians who presented earlier were using the Neurogym Biofeedback, so you'll see a little bit more about this in my presentation. For example, the client I worked with before, some chronic stroke clients were only able to use, to do minimal contraction of the wrist extensor, and using the EMG biofeedback game-based system, we were able to retrain their brain in order to control the wrist extension. And you'll see this in the video a little bit later. Also, with a lot of stroke clients, I've been using the bungee mobility trainer, and this is great because it allowed the client to experiment the fall, and therefore they can find out how to do the adjustment without risk of injuries. So all in all, whoops, I should have changed. Here we go. All in all, the Neurogym methodology developed by Dr. Native makes the state-of-the-art neurorehabilitation possible and applicable to your everyday practice, and all this for the benefit of the stroke survivor, obviously. So here we go with the clinical case. So presented by me, Ghislain Blanchard, and disclaimer, we skip this. So quickly we go over the patient history. I'll try to explain to you a little bit of the timeline, how the rehabilitation happened. And for the upper extremity case, we go through initial assessment, treatment, reassessment results, and his current status, and the take-home message. And we'll do the same for lower extremity. So the client I'll be talking to you about today he's not anymore 45, but he was 45 years old when he had his stroke. He's a very active guy, and he had no specific past medical history and no specific stroke risk factors. Actually, it's a pretty interesting story because the client was actually preparing for a half marathon just before his stroke. He had a stroke in September 2007, and he was admitted to hospital for 2 weeks. He only stayed 2 weeks in the hospital setup, then transferred in a rehab center. He did his first consultation in 2007 in mid-November at Neurogym, and because he was anticipating his discharge from rehab, and he was actually at the time 7 weeks post-stroke, and he had just started to walk sometime with a cane, but with a very inappropriate gait pattern. Actually, he was told he would not be able to walk again, but he's a pretty stubborn gentleman. And then he was discharged from the rehab center in December 2007, and he's still actively trained at Neurogym currently. So, for the initial assessment, I just put you a little bit of information here about range of motion and strength. At the shoulder and elbow, overall, there was very minimal movement, very minimal active movement. Sometime in the shoulder a little bit, but not much. And at the wrist, there was absolutely nothing. Not even 1 out of 5, not even palpation. The Chidoki McMaster was not performed at the time, but from the initial assessment, I can say that at the very best, the arm was at 2 and the end was at 2 as well. But that's the very best. And the client did experiment at the time some occasional shoulder pain. Now, the treatment we used from 2007 and 2009, we had to start with EMG training for the shoulder, elbow, and wrist. And the reason why is because, as I just told you, there was no active movement in the wrist, for example, no palpable muscle activity, but that doesn't mean that there is no EMG signal, and this is very important. So we were able to play a little bit with the EMG signals to work on wrist extension, on elbow extension, and on shoulder movement, without movement. So initially, it's very important to do so even if there's no active movement in order to avoid the learn non-use, which is everywhere in the literature right now, and also to optimize the neuroplasticity, because by activating the muscles in an intensive, speed-sensitive, and repetitive manner, even if there's no motion, then we can work on the brain plasticity and avoid the learn non-use. And later on, one thing that's very interesting with the EMG training is that even once there start to be some movement in the elbow or shoulder or wrist, it's good to use in order to avoid the co-contraction. And this is what we've been doing a little bit later on when there was more active movement. And especially if you think about elbow extension, there's often co-contraction, bicep, triceps. So using the EMG biofeedback, it helps the client to be able to dissociate those movements. And I find out, this is my personal experience, but I find out that some light resistance sometimes helps quite a bit. Also, from the beginning, as much as possible, and even if we had some shoulder pain, we try to do a lot of weight-bearing activity. I'm saying even if we had some shoulder pain, I know sometimes it's a no-no when there's shoulder pain, but we found a way to do it without exacerbating the shoulder pain, and it's important to be able to do so. Some example were doing 4-point exercise on the Swiss ball and using the Smith machine, doing shoulder push-up, for example, and active assisted. And we often in all the therapy, we try to combine the biofeedback, the Neurogym Biofeedback System, just because it brings much more intensity and it's speed sensitive, and it makes the exercise more fun, and then the client does it for a longer time. Also, for the upper extremity, we did a graded active assisted exercise. As I told you a little bit before, we use a lot of pulley system and also the pendulum stepper, and also the arm bike. At the beginning was bilateral and later on was unilateral. And also we include, as soon as possible, some strength training. And even if the client cannot do it by himself, we kind of assist him, but we still put some weight. And this is good, obviously, to increase control and increase strength. So this is a video. Unfortunately, I don't have the video of the client I'm telling you about, but this is a client I saw yesterday, actually. So you see what we can do with some biofeedback. This is a camera-activated biofeedback, and I'm doing active-assisted shoulder abduction. C'est ça. C'est ça. Okay. Okay, game over. It was a quick video, but I think you guys could see a little bit of the active-assisted shoulder abduction. So back to my client I was telling you about. In the summer 2010, I had some a reassessment done, and shoulder flexion was then at 45, abduction at 75. Elbow active range of motion improved, but there was still some active range of motion lacking. And very importantly, the wrist, there was minimal signal for extension, as I was telling you at the beginning, even if it was not a palpable contraction. And that was a beginning for us to use the EMG biofeedback. Later on, the client also did purchase Cyboflex. Maybe some of you guys are familiar with that. And it was very interesting to combine this, the Cyboflex with the biofeedback, with the finger sensor that was presented a little bit earlier. And the client was able to control the game with minimal movement, minimal motion of the finger. And we did that 30 minutes per session. So I'll just show you a little example. Again, this is not the original client, but somebody yesterday. Vas-y, bouge en masse. Bouge en masse. Je peux faire le TDH? Non.
Je te jure, j'adore le nouvel album de leur fille. Tu dois l'écouter. Je te jure, sinon tu sors pas si tu l'écoutes pas. Est-ce que t'as un téléphone au moins, Gislain? T'as un BlackBerry, toi, right?
So maybe you understood that he was asking me about if I had the BlackBerry or not, but that's not really relevant. But importantly, you can see was not able. This client, for example, was not able to do a lot of motion, but enough to control the game. And we can set up the game differently. In this example, it was on proportional, so the movement is proportional to how much movement it does. And this is very good for example for proprioception. But it's also possible to set it up differently on threshold, where it has to reach a certain amount of active finger extension in order to make the paddle move. And then we encourage the client to reach more and more range of motion actively. Now, in March 2011, the active wrist extension started, and the client could go from 10 degrees of flexion to neutral. So it's not purely extension, but still he does the extension movement. And since there was some motion in the wrist extension, we changed the therapy. We went from EMG activated biofeedback for the wrist extension that we were before doing to motion activated biofeedback. Okay, and just more data. In April 2011, the wrist extension was up to 15 degrees. And the Chidoki McMaster was then performed, and the stage of the arm was 3 and the end was 4. So that's, as you guys know, the prognostic for upper extremity recovery is not so good most of the time. So that's pretty impressive, I find. We were also doing, starting in September 2012, the client started to focus only on rehabilitation of his upper extremity, and you'll find out why later on. So we were doing more intensive work on the upper extremity. So still we were doing some strength training in all range available, and we also include some coordination and control exercise, again with the biofeedback system, but also doing some peg board, block manipulation, doing maze on a whiteboard, and trying to put X on the whiteboard in order to work on steadiness, for example. And sorry, I didn't erase the go abs go. So here's an example of the biofeedback exercise that was done with the client. As you might know, they often go in flexion synergy. So here's how I try to work again the flexion synergy. Here's the video. So I help him a little bit there, but not much. And the game is actually activated by the elbow goniometer. Okay, and we do this over and over in a repetitive, intensive, and speed-sensitive way. Another exercise that I did with the Neurogym Biofeedback, and that's the nice thing about it, we can be quite imaginative. The client really liked coffee, so we start working on grasp and release activity, and we were doing it with the coffee cup, but I put some of the finger sensor, a pressure sensor on the coffee mug, and he had to be able to grasp it, but more importantly, being able to release it a little bit. As we know, it's more difficult to open the hand. And that was an actually pretty good exercise, and we did it again in an intensive, repetitive, and speed-sensitive way. One more exercise that I use for is upper extremity, and this one I really like to. I called it reach and tap. So this is not patented. You can copy it if you want. So pretty much it was elbow extension and opening the hand to reach a pressure sensor, which was put about 40 centimeters in front of him. And the nice thing about it is that I also put an alarm goniometer on the elbow. So the client could not cheat by just doing trunk flexion. He had to actually extend his elbow in order to reach a pressure sensor. In this way, we work on elbow extension, on the reach and grasp movement, and we avoid the compensation. If the client was not extending the elbow enough to reach the pressure sensor, then it would beep and the game would not be activated. And the sound is pretty annoying. So, I gave you an overview of what happened for rehabilitation. Right now, I can tell you that the client can do full shoulder abduction, elbow extension and flexion, wrist extension, and this we really work very intensively on these since September 2012, and can do grasp and release action. So yeah, and as I told you, only since September 2012 we've been doing very intensive work on the arm, and this is roughly 5 years post-stroke. So this is a chronic stroke client. So for him, more importantly, he can now drink his coffee with the affected hand without spilling too much on his shirt. And he shakes hand in a closer to natural manner. And this is important because we're talking about a businessman here, and his right hand was affected. Now, what's next? Right now, we started to put together a RTMS protocol at the Clinique Neurogym in Gatineau in Ottawa region. And we'll involve the client in a protocol where we'll combine RTMS, so repetitive transmagnetic stimulation, with intensive rehabilitation. And I'm sure some of you might have some question about RTMS, but that would be another presentation. So the take-home message: with a proper rehabilitation program for the upper extremity, even if the prognostic is not so good usually, there's a way and a rehabilitation program including intensive strength training, coordination, control training, and weight-bearing activity, combined with EMG or motion-specific biofeedback. It can lead to significant change in the client's life, and this far beyond the so-called plateau. So I don't know if you guys have questions about this specific presentation. I'll wait a little bit, and otherwise I'll go on with the lower extremity. No question? Starting to wonder if they hear me, though.
Can you still hear us here?
This is the U of A. Yep, we can hear you fine.
We can hear you.
Yeah, we can hear you in Meadow Lake as well. If you could just continue.
We'll keep going then.
That would be great. Thank you.
Okay, continue. Maybe if you have questions, we can do it at the end. All right, so now I'll talk about the lower extreme.
Oh.
Yes?
Oh yes, we just
go ahead.
The cost of like the setup.
The cost of the setup?
Can we just take that offline, because it's a complicated question depending on sensors? But why don't we just go through this case and maybe we can answer that at the end?
Okay, thanks a lot.
Okay.
Okay.
So now back to the lower extremities, and obviously if you have more questions, keep it for the end. I'd be happy to answer. Here we go. So a long journey to complete a half marathon. That look impressive, but it is actually impressive. So again, I'll go through the same kind of plan to present to you this case. I'll go a bit quicker though, because I don't think I have much time left. So basically at the initial assessment, still in 2007, roughly like standing feet together, the client was unable to do it. Standing on one leg on the affected side was not thinkable, and jumping with support, obviously unable. Remember that the client came in the clinic and he just started to walk sometime with very inappropriate gait, and was told he wouldn't be walking at all. So mobility-wise, he would be able to do sit to stand, but with some close supervision. As I just told you, he would walk sometime with a cane, but not a good gait pattern, very much specific of the stroke client. Knee hyperextension, foot flap in swing face, and ankle inversion. Strength-wise, he had some strength at the hip, about 3-, at the knee too, but not full active range of motion, but near full. And for the ankle, he had very minimal activation, some palpable muscle contraction, but no more than that. So this is not the client I'm telling you about. This is another client I'm currently seeing. But for mobility, we use the Bungee Mobility Trainer, which is overall it's a body weight support system, but it allows the client to move in a very natural manner. So we did work on gait pattern, on weight-bearing activity, and we actually later on we did some running exercise, because remember the client was training for a half marathon. We also do side step, jumping, and jumping is actually possible. It's possible to do it even if the client is unable on his own, because we can boost the body weight support system. For example, I can remove from myself 100 pounds, which is pretty good. So it allows clients to experiment stuff they would not be able to experiment otherwise. And remember, we're aiming at neuroplasticity there. We're aiming to enable the movement. So again, in the bungee, balance and stability, we did a lot of this. We do a lot of side-to-side weight shift in order to bring the client back on his hemiplegic, hemiparesis side. We do it combined with the biofeedback, with what the previous presenter showed you, the pressure sensor. So we force going over the hemiparesis side. We also work on antero-posterior weight shift, going back and forward and back in order to work on the cone of stability for balance. We do static balance activity like tapping the...
There are 10 minutes remaining in this video conference session. Please contact VTAC if technical assistance is required.
Okay, 10 minutes remaining. So, and we also do dynamic balance activity, and this is very interesting because with the bungee, it allows you to do stuff you wouldn't be able to do otherwise. I'm thinking, for example, about the Berg balance scale number 12, doing the alternating foot tap on the little stand there. So often it's impossible to do, but if you give the client some body weight support and you allow them to try, they can be trained. And one other thing that we can do is a protective step. So it doesn't sound very good, but often I will push my client in order for them to be able to take this one step that would prevent them from falling. If you want to be able to have a better balance and walk better with the walking aid, you should be able to have the proper reaction without the walking aid. And maybe I can tell you quickly about the stop, tap, and kick. This is a dynamic exercise. It's not patented, but I'd be happy if you steal it from me. Basically, it's stopping the balloon, tapping on top, and kicking it back. If you do it with the hemiplegic side, you work on control and coordination. But if you do it with the non-affected side, you work on weight shift over the affected side. And this is very efficient and quite simple. Control and coordination. One of the things that I told you about my client at the beginning, and often your client will be similar with the knee hyperextension. So I use the goniometer biofeedback system in order to work on a proprioception of the knee. and especially at the very little range of extension, close to hyperextension. And I will put something, you can adjust it so when it goes in hyperextension, it beeps and the game stops. So it's good to retrain the client not to go in hyperextension. And just because a video is always better than my explanation, I'll show you here. So with this client, we're controlling the game with knee flexion, very little. And I make sure each time if she goes in hyperextension, the game will stop and it will beep. So you see how proprioception of the knee can be trained like this. Okay, it's always the ping pong I use most of the time. It's not the most exciting game, but it's simple enough so the client can work. And there's nice progression to be done there, and that's what I did with the client. So we start with both knees in the bungee mobility trainer for body weight support, and then you can go to single leg stand with a lot of body weight support, and eventually to single leg stand with no bungee and no support. I told you about the bird task number 12 earlier. I also work on ankle proprioception, and control with the ankle trainer and the biofeedback, very similar to what you just seen, but with inversion, eversion, and dorsiflexion. And I use the ankle trainer as well for strength training. At the beginning, the client, you saw he had 1 out of 5 for muscle strength for the tibial anterior tibialis. So I started with the EMG biofeedback, but then I quickly progressed to motion-activated biofeedback. And obviously, we include some strength training, leg press, leg extension, and flexion, ankle trainer, dorsiflexion, eversion, and etc. So here's some data. So for example, at the initial assessment, I told you was unable to stand on the right leg and able to stand a little bit on the left. With a lot of work, now he's able to stand for like over 15 seconds on the right leg and over 25 seconds on the left leg. So that's pretty good. Also, he's now able to walk and run, actually to walk quite fast and to run not too bad neither. So he did 50 meters in about 19 seconds. That's his best time. And this is not in the bungee mobility trainer. This is without it. His gait pattern improved quite a bit. So less hip hike, less circumduction. He's able to perform heel strike now. He controls his knee better. He doesn't go in hyperextension at every single step. And I'll show you a little video on the next slide. So for community balance and mobility scale, maybe you guys are familiar with that. In December 2008, he was at 45, and he's not, in April 2010, he's now at 55, and I didn't have a chance to reassess him on this, but that's quite a significant improvement. So I show you now his walking. This is 2 years ago, but it's still pretty good. And remember, he was not walking or walking pretty badly with a cane when he walked in the clinic. Okay, and then fast. So as you might have seen, heel strike is not too bad. He doesn't do hyperextension of the knee. And maybe you notice his hand, his right hand. So you can see it was not very active there. So here's some not so standardized reassessment results for endurance and mobility. So now 5 years post-stroke, the client did complete his half marathon in less than 4 hours. That was walking, quite obviously, but this is quite an achievement. And this is one of the reasons why we start focusing on in September 2012 on upper extremity, because he did achieve his goal of rehabilitation, of being able to complete his half marathon he was training for at the moment of the stroke. And remember, he was initially planned to be discharged from rehab in a wheelchair, but I think the fact he was stubborn paid off. So current status, he now walks. He's happy with his gait. He did his half marathon. He still does some training. We still work on his lower extremity just for maintenance, but mainly focusing on upper extremity. And the goal for this summer is to be able to ride his bike. The take-home message here is that the notion of motor recovery plateau in motor control should probably be reconsidered for stroke survivor. And this even once he reached the chronic stage. And there's more and more literature about this. reconsidering the so-called plateau. Also for physiotherapists, it's not always easy, but we need to aim to find some ways for the client to experiment with otherwise unattainable movement in order to pass the famous plateau. So sometimes we need to adapt our training to change it a little bit and to find different ways to enable the movement for neuroplasticity again to take place. Still in the take-home message, I think poor posture and balance should not prevent the therapist from creating mobility-enabled movement environment. So we should maybe be a little bit less picky about being sitting in the perfect posture and everything, and instead concentrating our energy on finding enabling environment for the client to experiment movement and therefore modify neuroplasticity. And this is just a quote from an article 2004, which is pretty old now. So findings suggesting that the patient with chronic stroke can benefit from rehabilitation programs that apply novel or different parameter and mobility and modalities.
Your conference is scheduled to end in 2 minutes.
Okay, I'm about to be done. So anyway, so I'll leave you on this quote because I think it's very important to...
Your conference is scheduled to end in 2 minutes.
Okay. So thank you very much for your attention. Sorry, my English is not perfect, but I hope you guys could understand most of it. And I'll take your question right now. Thank you.
Thank you very much, Kevin. This is the U of A site, and unfortunately, I'm afraid we won't have time for questions. I think we're going to be cut off here right away. And I did want to mention that for those of you who have attended, if you can fill out your evaluation forms and send them to us, we are compiling your hours for a certificate at the end of the year, at the end of June. There is on the handouts, there is contact information for Kevin, Kevin Mansfield, kevin@neurogymtech.com. So if you do have questions, unfortunately, I'm sorry with the technical difficulties, we apologize, but we did run out of time. You can forward them directly to Kevin or to Mary Lou Hallaby and myself, Gail Elton Smith at albertahealthservices.com, and we'd be happy to forward those questions on. So thank you very much, Kevin, and we appreciate it. It was really good.